Hi again. Welcome to the pre-class PowerPoint on endocrine part 1. Now, we've been talking all quarter about trying to understand the disease processes from a logic standpoint and not just memorizing things. And the good news is that for the endocrine system, that's probably one of the easiest systems to do that with because, if you get right down to the bottom line, the job of the endocrine glands is to make hormones. And for most endocrine diseases, especially the ones that we're going to study this quarter, the primary problem is that the endocrine gland is either making too much hormone or not making enough hormone. So what that means is that as long as we know what the hormone does, it's just a matter of logic to figure out what problems are going to happen if there's too much of the hormone and what problems there are going to be if there's not enough. So, we said that the job of the endocrine gland is to make hormones. So our first logical question is, what is a hormone? Well, a hormone is just a chemical messenger that's produced by an endocrine gland that gets transported in the blood and body fluids, and it affects the activity of specific target cells. And in that way, the hormone helps integrate or regulate the activities of other body systems. Now, the hormones work by binding to a receptor site on a target cell, and when that hormone, that chemical messenger, binds to the receptor site, that's the signal for some specific predetermined event to occur inside that second cell. Now, even though pretty much all cells in your body are exposed to a particular hormone once it gets into the blood, only the target cells for that hormone have the receptor sites on their cell surfaces. So only the target cell is going to respond to the hormone. Of course, once the hormone's done its job, then we have to inactivate it and excrete it from the body. Otherwise, it's going to build up to toxic levels and cause problems. Now, some hormones are inactivated right there at the receptor site once it's released from the target tissue. But others will be circulated around to the liver and get inactivated there. And from that point, the inactivated hormones are excreted either in the urine by the kidneys or in the bile by the liver. So, it's a pretty good system, but it only works if all of the parts of that system are functioning properly. Now, where do you see in this system that something could go wrong? Maybe your endocrine gland is producing too much or too little hormone. Or maybe there's a problem with the receptor site. Even if the appropriate amount of hormone is present, if there's something wrong with the receptor site, then you're not going to get your desired effect. Maybe the target tissue is the problem. Okay, so even if you have the right amount of hormone and the receptor site is working, if the target tissue doesn't work, then you're not going to get your desired effect. Okay, for example, think about the hormone antidiuretic hormone. It's supposed to tell the kidneys how much water to save or get rid of. So even if there's the right amount of antidiuretic hormone, and even if the receptor sites are functioning, if your kidney has failed, then you're not going to get your desired effect. Okay, and finally, there might be a problem with your liver or your kidney. Okay, remember the hormones are supposed to be broken down and excreted by the liver and the kidney. So if there's something wrong with the liver or kidney, then the hormones are going to build up to toxic levels and you're going to see problems with imbalance. Okay, I've listed for you on your study guide, and then you can see also in this picture some of the major organs or glands in the endocrine system. And in your study guide, I've also listed some of the primary hormones that they produce. Now, we don't have time to talk about all of those hormones or all of those glands. So right now, what I want to do is I just want to talk about the two that are the most important in regulating endocrine function. And the two glands that are most important in regulating endocrine function would be, what do you think? The pituitary and the hypothalamus. Okay, now we're going to talk about some of the other glands as we cover some of the common endocrine disorders. But for right now, we're just going to look at the pituitary and the hypothalamus. All right, let's look at the pituitary first. Sometimes we call the pituitary gland the, quote, master gland, because a lot of its hormones actually help control how much hormone some of your other endocrine glands are going to produce. So we call it, quote, the master, okay? Now, you can see in the bottom picture on this slide that the pituitary does have two parts, right? There's the anterior pituitary and the posterior pituitary. The anterior pituitary is the part of the pituitary that makes what we call tropic hormones. And the tropic hormones are the ones that tell some of the other endocrine glands how much hormone to produce. And you can see the three black arrows are pointing towards those hormones that the anterior pituitary produces that we consider tropic hormones. Okay, we have TSH, which stands for thyroid stimulating hormone, and TSH tells the thyroid how much thyroid hormone to produce, as well as stimulates the thyroid to get bigger. ACTH stands for adrenocorticotropic hormone. And so right there in the name, you know what endocrine gland gets influenced, right? Because adrenocortico refers to adrenal cortex. So the amount of ACTH that's present helps determine how much cortisol and androgen your adrenal cortex is going to produce. Now, remember that your adrenal cortex also produces aldosterone, right? But ACTH does not tell your cortex how much aldosterone to produce. Do you remember what is it that tells your adrenal cortex how much aldosterone to produce? It's the kidneys, right? Through the renin-angiotensin-aldosterone system. Okay, so while the kidneys regulate the amount of aldosterone from the adrenal cortex, ACTH from the anterior pituitary is what tells the adrenal cortex how much cortisol and androgens to make. Okay, and then the last two tropic hormones, FSH and LH, stands for follicle stimulating hormone and luteinizing hormone, although in men, sometimes we call it, instead of calling it luteinizing hormone, we call it interstitial cell stimulating hormone, or ICSH. But anyway, whichever name you want to call it by, FSH and LH help regulate the amount of hormone that's produced by your reproductive organs. Okay, so in women, it helps regulate the amount of hormone from your ovaries, and in men, helps regulate the amount of hormone from the testes. In this picture, we've just got another way to look at the idea of the anterior pituitary producing tropic hormones that tell the thyroid and the adrenal cortex and the reproductive organs how much hormone they should be making. So obviously, if you have a problem with your anterior pituitary and we mess with the levels of tropic hormones that they produce, then we're probably also going to see some problems with the amount of hormone that the thyroid, the adrenal cortex, and the reproductive organs are producing. All right, let's look at the other gland that's important in regulating endocrine function, the hypothalamus. Anatomically speaking, the hypothalamus is part of the central nervous system. But because it does produce some hormones that affect the function of the pituitary gland, it needs to be part of our discussion today. Now, the endocrine system and the nervous system actually work very closely together. They affect each other's function. They share some of the same chemical messengers. In fact, a lot of experts don't look at those two systems as two totally separate systems, but as one great big giant neuroendocrine system. And the link between those two systems is between the hypothalamus and the pituitary. Now, the hypothalamus affects the function of both the anterior and the posterior pituitary. One of the things the hypothalamus does is it gets input from a lot of the other body systems, and in response to that input, it will produce releasing or inhibiting hormones that then travel in the blood and basically tell the anterior pituitary how much tropic hormones that it should be producing. So you see where the red arrow is pointing, those are a listing of the releasing and inhibiting hormones that the hypothalamus produces that then in turn affect the tropic hormones that are produced by the anterior pituitary. So in the second row, where you have the purple color in the background, those are the tropic hormones that are affected by the releasing hormones that the hypothalamus produces. Now, the hypothalamus is actually even more involved with the posterior pituitary than it is with the anterior pituitary, because if you look at this picture, you can see that the posterior pituitary is actually sort of like an anatomical extension of the hypothalamus. So if you look at where the two red arrows are pointing, you'll see that there's one end of the nerve cell that's in the hypothalamus, the other end is in the posterior pituitary. And all of the hormones that the posterior pituitary releases are actually made in the hypothalamus. They're just stored and released from the posterior pituitary. So you see that the hypothalamus really is even more involved in the function of the posterior pituitary than in the anterior pituitary. So it almost makes you wonder why we call the pituitary the master gland, right? When it seems like the hypothalamus is telling the pituitary what to do. Probably, I'm guessing the reason for that is because the hypothalamus really isn't a gland, right? We said it's part of the nervous system. So in that respect, I guess the pituitary is the master gland because the thing that's telling the pituitary what to do really isn't a gland. Okay, so if you think back to this little slide where we're looking at the releasing hormones from the hypothalamus and then the tropic hormones coming from the anterior pituitary, of course you can see how there are several places where something could go wrong, right? If you have a problem with the releasing and inhibiting hormones coming from the hypothalamus, then that can affect the amount of tropic hormone from the anterior pituitary, which then will affect the amount of hormone that are produced by the target glands, the thyroid, the adrenal cortex, the reproductive organs. So there's actually like 3 different levels of control here, 3 different places where something could go wrong. Let's look now at the actual process by which the amount of hormone that an endocrine gland produces is regulated. Most hormones are regulated through a negative feedback mechanism. And in its simplest form, the way the negative feedback mechanism works is that it monitors the amount of a hormone that's being produced and makes adjustments to keep the level of that hormone within normal limits. Okay, so it works sort of like the thermostat in your house. So you know the way a thermostat works, right? You set the thermostat at whatever temperature you want your house to be at, and the thermostat will monitor the temperature in the room, and if the room temperature drops and it's colder than you want it to be, the thermostat's going to turn the heater on, and then it continues to monitor the temperature. And when the temperature goes up above the level that you want it at, it's going to shut the heater off. Okay, so what we have here is the thermostat monitoring the room temperature and making whatever adjustments to the heater that are needed in order to keep the room temperature at the level that you set it at. Okay, so the negative feedback mechanism basically works the same way. In this particular example, you see what's going to happen is the feedback mechanism is going to monitor the level of thyroid hormone that's being produced, and that feedback is going to go to the anterior pituitary and to the hypothalamus, and if the levels of thyroid hormone are too low, the feedback's going to tell the hypothalamus and the anterior pituitary, make more TRH, make more TSH, And an increase in those hormones should make the thyroid make more thyroid hormone. Now that the level of thyroid hormone has gone up, the feedback's going to go back to the hypothalamus and the anterior pituitary saying, okay, I have enough hormone now. You can quit making the releasing and the stimulating hormones, and when the levels of those hormones drop, then the thyroid won't make so much thyroid hormone. And so through that kind of negative feedback and the adjustments that are made, we can keep the level of thyroid hormone within normal limits. So what we have here is basically a triple level regulatory system. Sometimes we call it the hypothalamic pituitary target cell system. And this affects your thyroid and your adrenal cortex and your reproductive organs. Now, sometimes it's not the level of the hormone that's being monitored in a negative feedback mechanism, but it's the effect of the hormone that gets monitored. For example, with the pancreas, what hormone does the pancreas produce? It produces insulin. Okay, but in this particular feedback mechanism, what's being monitored is not the level of insulin, but what's being monitored is something that insulin affects. Now, what does insulin affect? It affects blood glucose levels. So in this particular feedback mechanism, what's being monitored is the blood glucose levels. And if the blood glucose levels are too high or too low, that's the feedback that goes back to the pancreas and tells the pancreas how much insulin to make. Antidiuretic hormone is another example of a hormone that's monitored in that same way. Now, while most hormones are regulated by that negative feedback mechanism that we just talked about, there are a few hormones that are regulated more along a time-based or a cycle type of pattern. And probably the best example of that is the 28-day cycle that the female sex hormones go on. And I'm sure you're all familiar with that. All right. So, again, the general concept behind most endocrine disorders is pretty simple because most diseases can be categorized as either a hyperfunction or a hypofunction problem. Or as you see in this chart, it can be a overproduction or an underproduction problem. What that means, though, is, again, you've got that logic that's very obvious. As long as you know what the hormone does, you can figure out what the problems are going to be if there's too much of that hormone or if there's not enough. Now, I want to look at the kinds of things that commonly cause hyper and hypofunction problems for endocrine glands. But the thing is, the kinds of things that cause hyper and hypofunction problems are pretty much the same regardless of which endocrine gland you're talking about. So what I want to do now is I want to look specifically at common causes of hypofunction of endocrine glands and common causes of hyperfunction of endocrine glands. We'll talk about it as a group now, so we don't have to talk about it separately for each individual disease. Okay? So, common causes of hypofunction of an endocrine gland, or in other words, problems that cause the gland to produce too little hormone. Problem could be a congenital defect. Sometimes people are born without a particular endocrine gland, or sometimes they're born with a gland, but it doesn't work. So then you see not enough hormone being produced. Sometimes people are born with a functional endocrine gland, but somewhere along the line, the gland gets damaged, either because of ischemia or because of inflammation or infection. Maybe an autoimmune disease or a cancer is damaging the gland, so now it's no longer able to produce adequate amounts of hormone. Sometimes a hypofunction problem is a factor of aging. You know, we've been saying all quarter that as you get older, everything in your body gets less efficient and less effective, And the same is true for endocrine glands. Sometimes as you get older, the gland just starts producing less and less hormone. And it may get to the point where the gland is producing so little hormone that you have a hypofunction problem. Or it might be a problem with the receptor site. You remember that we said the job of the hormone is to bind to a receptor site, and that triggers some event to happen inside the cell. Now, even if you have appropriate amounts of hormone or chemical messenger, if there's a problem with the receptor site, then the hormone can't do its job. So it looks like there's a hypofunction problem. That's another potential cause of hypofunction. Finally, sometimes we create a hypofunction problem in our patients by prescribing them hormone therapy. Probably the most common example of that would be when we have patients who have different kinds of inflammatory diseases like asthma or inflammatory bowel disease. And the way we treat those diseases is we put patients on hormone therapy with synthetic glucocorticoids, because synthetic glucocorticoids have anti-inflammatory properties. But the problem with that is when we prescribe these glucocorticoids in fairly large amounts, what happens is we throw the negative feedback mechanism off, and that creates a hypofunction scenario for our patients. Okay, so in this picture, you can kind of get an idea of what happens. Let's say we put somebody on synthetic glucocorticoids, or it's like a synthetic cortisol type of medication like prednisone or hydrocortisone or dexamethasone. Okay, those are examples of synthetic cortisol. And we give it because it has anti-inflammatory properties. But if you give somebody synthetic cortisol, the feedback mechanism, as you see from the black arrows, the feedback mechanism is telling the hypothalamus and the anterior pituitary, you know what? I got a ton of cortisol. You don't need to tell the cortex to make any more. Okay, so the hypothalamus and the anterior pituitary will decrease the amount of releasing hormone and ACTH that it produces, and that will tell the adrenal cortex, stop producing cortisol because we have plenty. Okay, now if that continues and we continue to give people synthetic cortisol, the adrenal cortex always gets the signal, you don't need to make cortisol. And so over time, what happens is the adrenal cortex atrophies, right? Because it has nothing to do. The signals keep telling it, you don't need to make cortisol. And so it just kind of kicks back and it just atrophies. The problem being, once the cortex atrophies, if for some reason we stop giving that synthetic cortisol, well, the cortex is all atrophied and it can't produce any cortisol. And so then you're going to look like you have a hypofunction problem. So you see, in that little scenario, we've actually created the hypofunction problem because we were giving hormone therapy with synthetic glucocorticoids, synthetic cortisol. Okay, and that actually happens quite frequently. We'll talk about that a little bit more when we get into some adrenal diseases. All right, let's talk about common causes of hyperfunction of endocrine glands, or things that cause the endocrine glands to produce too much hormone. Of course, one obvious cause is if you have a tumor on that endocrine gland that is growing and it's overproducing hormone. But you remember that we also said that there are certain kinds of cancers that do produce ectopic hormones. And remember we said that ectopic hormones were hormones that looked almost just like the hormones that your endocrine glands produce. Only instead of coming from your endocrine glands, they're coming from the cancer cells. Okay. So let's look at how that might work. Okay, so in this slide you see there's a patient and he has a lung tumor that's producing ectopic ACTH. Okay, and that increased amount of ACTH is making the adrenal cortex produce a lot of cortisol. Okay, now since there's a lot of cortisol, the feedback's going to go back to the hypothalamus and the anterior pituitary and saying, you know what? I got a ton of cortisol. So you don't need to make any more CRF. You don't need to make any more ACTH. You know, I'm fine. I got plenty of cortisol. Okay. Now, even though the feedback mechanism is working correctly and the anterior pituitary is not making ACTH anymore, we still have a ton of ACTH because the lung tumor is not influenced by the negative feedback mechanism, and it's still going to make a lot of ACTH whether you already have a lot or not. So because of that, we still have a lot of ACTH. The adrenal cortex is still going to make a lot of cortisol. So we end up with a hyperfunction problem because of that ectopic hormone that's being produced by the cancer cell. Okay, autoimmune disease, another potential cause of hyperfunction diseases. Now, when you first think about that, it seems kind of counterintuitive, right? Because usually when you think about an autoimmune disease, you think of the immune system making antibodies against its own tissue, and so you would expect autoantibodies to be destroying endocrine glands and causing a hypofunction problem instead of a hyperfunction problem, right? And that does happen, but sometimes something else happens as well. So in this slide, you can see that the autoimmune autoantibodies, instead of destroying the endocrine gland, are actually abnormally stimulating it. So you see the TSH receptor sites on the thyroid cell. See how the autoantibody is actually stimulating those receptor sites? And so that's causing the thyroid cells to produce increased amounts of hormones. And so here you see how an autoimmune disease can actually cause a hyperfunction problem instead of a hypofunction problem. So in this slide, you see examples of both kinds of autoimmune diseases. On the left, you see the autoimmune disease that you normally think of, where the immune system's making these autoantibodies that are destroying self-tissue. It's destroying the thyroid gland. On the right, you see the autoimmune process where the autoantibodies are actually abnormally stimulating the gland and producing a hyperfunction problem instead of a hypofunction problem. The last concept I want to cover in this PowerPoint is primary versus secondary endocrine disorders. Now, a primary endocrine disorder is caused by a problem with the gland that normally produces the hormone that's out of balance, whereas a secondary endocrine disorder is not caused by a problem with the gland that actually produces the hormone that's out of balance, but the problem is coming from somewhere else. Usually, it's a problem with whatever mechanism is regulating how much hormone that endocrine gland is producing. Let me give you an example. Okay, let's say you have a patient with an imbalance of thyroid hormone. If that imbalance is because of a thyroid problem, that would be a primary endocrine disorder. If, however, the imbalance of thyroid hormone was being caused by a problem with the anterior pituitary or a problem with the hypothalamus instead of a problem with the thyroid, then we would consider that a secondary problem. Okay, so in this particular picture, the column on the right, it's indicating that there's too much cortisol, and the problem is with dysfunction of the adrenal cortex. Okay, now since cortisol is made by the adrenal cortex, that would be a primary disorder because it's a problem with the gland that actually produces the hormone that's out of balance. In the middle column, we've got still a problem with too much cortisol, but now the problem is not with the adrenal cortex. The problem is with the anterior pituitary. The anterior pituitary is making inappropriate amounts of ACTH, which is telling the adrenal cortex to make inappropriate amounts of cortisol. Since that is not a problem with the gland that actually produces cortisol, but it's a problem with the regulatory mechanism, we call that a secondary disorder. In the far left column, now we have a situation where, again, we have too much cortisol being made, but it's not because of a problem with the adrenal cortex. It's not because of a problem with the anterior pituitary. It's a problem with the hypothalamus. So again, we call it a secondary problem because it's not a problem with the gland that actually produces the cortisol. It's a problem with the regulatory mechanism. Now, sometimes we refer to problems with the hypothalamus as tertiary instead of secondary. So we would have primary as a problem with the adrenal cortex, secondary as a problem with the anterior pituitary, and tertiary as a problem with the hypothalamus. But in a lot of textbooks, instead of primary, secondary, and tertiary, you'll just see them refer to primary and secondary. And in those circumstances, anything that is not primary is considered secondary. Okay, so usually primary disorders are a problem with the gland that produces the hormone that's out of whack. Anything else is a secondary problem, and usually that, quote, anything else is a problem with the regulatory mechanisms. Whatever it is, whatever body part that regulates how much hormone is supposed to be produced. Now, in a lot of cases with the thyroid, with the adrenal cortex, with the reproductive organs, a lot of times those regulatory mechanisms are the anterior pituitary and the hypothalamus, but not always. Because you remember we said, okay, aldosterone comes from the adrenal cortex, but aldosterone is not regulated through the anterior pituitary and ACTH. Remember what controls the amount of aldosterone that you produce? It's the kidneys, right? Through the renin-angiotensin-aldosterone system. So in this particular case, a secondary disorder of aldosterone imbalance would not be a problem with the pituitary or the hypothalamus. It would be a problem with the kidneys.
All right. That's about all of normal function of the endocrine system that I want to cover today. Let's look now at some disorders of specific endocrine glands, starting with the thyroid. So you remember that the thyroid makes 3 hormones, right? It makes T3, or triiodothyronine, it makes T4, or thyroxine, and it makes thyrocalcitonin, sometimes just called calcitonin. I actually want to talk about calcitonin first. So what does it sound like thyrocalcitonin is involved with? Calcium, right? The job of thyrocalcitonin is to lower blood calcium levels, which means it does the exact opposite thing that parathyroid hormone does, right? Because the job of parathyroid hormone is to raise blood calcium levels. So between thyrocalcitonin and parathyroid hormone, together, they determine what your blood calcium levels are going to be. Now, because thyrocalcitonin and parathyroid hormone kind of balance each other out, if someone were to get thyroid disease and they were making too much or not enough thyrocalcitonin, we really wouldn't have to worry as long as the parathyroid is working correctly, right? Because if the thyroid's messing up and not making enough thyrocalcitonin, all the parathyroid would have to do is not make as much parathyroid hormone, and calcium levels should stay normal. If the thyroid is messing up and making too much thyrocalcitonin, all the parathyroid would have to do is make a little bit more parathyroid hormone, and that should balance it out, and calcium levels should remain normal, right? So the bottom line is, as long as the parathyroid is functioning correctly, we really don't have to worry about calcium levels in thyroid disease. So when we talk about hyper and hypothyroidism, we really only worry about the levels of T3 and T4. Does that make sense? So let's talk about T3 and T4. T3 is called T3 because it has 3 iodine atoms in it, and T3 is actually the active form of the hormone. T4 is called T4 because it has 4 iodine atoms in it. And T4 actually needs to be converted to T3 before it's physiologically active. Okay, so basically T3 and T4 are the same hormone. It's just that T3 is the active form of the hormone and T4 is the inactive form. Because they're basically the same thing, when we talk about thyroid disease, we usually refer to levels of thyroid hormone. We don't necessarily differentiate between T3 and T4. And that's basically what we're going to do today. We're going to say, thyroid hormone levels are up or thyroid hormone levels are down, and you'll know that we're referring to both T3 and T4. Now, if you were to ask most people what thyroid hormone does, they'd usually tell you something about metabolic rate. Okay, and that's correct. To be specific, thyroid hormone increases metabolic rate. And since heat is a byproduct of metabolism, thyroid hormone is also involved in thermal regulation. And finally, thyroid hormone is necessary for physical and mental growth and development. So if you were to have a baby who didn't have thyroid hormone, then you would probably be looking at some degree of physical and mental retardation, unless we were to replace the hormone. And that condition would be called cretinism, which you'll probably study more about when you get into peds. Okay, but this is the reason why we screen all the babies in the newborn nursery and check their thyroid hormone levels, because if they were to have low levels of thyroid hormone and we did not catch it and give them thyroid hormone replacement, then they would probably develop physical and mental retardation, which would have been totally avoidable, right? So now that we know what thyroid hormone does, let's talk about what symptoms we would expect to see if the patient had too much or not enough thyroid hormone. And we're going to look at them side by side like this so that we can compare the symptoms of each condition to each other, and so it'll become much more clear that their symptoms are basically opposite to each other. All right? So what we're going to do is we're going to talk all about hyperthyroidism first, and then we'll come back and talk about hypothyroidism so we don't get ourselves all mixed up. But we will keep them, on this chart so we can compare them side by side. All right, hyperthyroidism, sometimes called thyrotoxicosis. Thyrotoxicosis meaning toxic levels of thyroid hormone. So this is what happens when there's a higher than normal level of thyroid hormone. Now, there are several forms of hyperthyroidism. The most common type is an autoimmune disease that we call Graves' disease. And this is one of those weird autoimmune diseases where the autoantibodies are actually abnormally stimulating the thyroid, and so the thyroid is overproducing hormone. So, obviously, if there's too much thyroid hormone, that's going to increase the metabolic rate, and as it does increase the metabolic rate, it's going to sort of speed up all the body processes. Now that the basal metabolic rate is higher, we're going to need more oxygen, right? Because remember, you need oxygen to burn that fuel to produce the ATP, right? So since we now need more oxygen, what do you think is going to happen to the respiratory rate? It's going to go up, right? And people might actually complain of a little bit of shortness of breath. Now, once we breathe in that extra oxygen, we have to circulate that all to the body cells, right? And so what do you think needs to happen to cardiac output? We need to increase the cardiac output, right? So that we can improve the circulation to the cells. Now, the easiest way to improve cardiac output is usually to increase the heart rate and the force of contraction. Now, people are usually not going to sit there and say, I've been having a lot of tachycardia lately. But what they may tell you is that they've been having palpitations, because they may not necessarily perceive the increase in heart rate, but they will feel that increased force of contraction, and usually they're going to describe it as palpitations. Now, because the cardiac output is improved, people have better circulation, their skin is probably going to be warm, it's going to look flushed, and because of that improved circulation, their skin and their hair is going to be, nice and soft because there's more oil production, and, everything stays nice and moisturized. Now, remember, heat is a byproduct of metabolism, right? So if your metabolic rate increases, what do you suppose is going to happen to heat production? People are going to produce more heat, right? And so they may develop what we call heat intolerance. They're going to feel hot. They always want to turn on the air conditioner. They're flushed. They're sweating because they're producing all this heat. Now, what do you suppose is going to happen to the appetite of a hyperthyroid patient? Their appetite increases, right? But what happens to their weight? They lose weight. So how are they losing weight if they have an increased appetite and they're eating more? It's because their metabolic rate is so high, right? They're eating more, but they're just burning it up. Okay, so right about now, some of you are thinking, ooh, how can I get that disease, right? Because I can eat more and I can still lose weight. Well, not all the symptoms of hyperthyroidism are quite that nice. For example, what do you think happens to motility in the GI tract? Motility increases, right? And so what problem do people get? Diarrhea. All right, the other thing that happens that might not be very pleasant is when there's a lot of thyroid hormone around, people seem more sensitive to epinephrine and norepinephrine. And you remember, epinephrine and norepinephrine are your neurotransmitters in your sympathetic fight or flight response, right? So when people have hyperthyroidism, they seem like they also have an overactivity of their sympathetic nervous system. And if you think of those things that happen when you have that fight or flight reaction, it's stuff like anxiety, restlessness, tachycardia, pale, cool, clammy skin, feeling of impending doom, okay? So you can imagine this is not necessarily the most pleasant way to feel, right? People get nervous and anxious. They can't sleep. They are kind of hyperactive. They have trouble sitting still. If you can get them to sit still, they might have a slight tremor. They get very irritable and they get very tired, but they can't sleep because they have this insomnia. So it is very kind of unsettling, the kinds of feelings that they have. Now, if the hyperthyroidism is caused by Graves' disease, there are 2 additional changes in physical appearance that you might notice in addition to the weight loss. Okay, and those 2 changes would be a possible goiter and exophthalmos. Okay, let's talk about exophthalmos first. Now, what does it sound like exophthalmos has to do with? What body part? The eyes, right? Because that root ophthal has to do with your eyes. That's the reason why you go to the ophthalmologist to get your eyes checked. And he uses an ophthalmoscope to look in your eyes, right? Exophthalmos refers to the bulging of the eyeballs. You see how in this patient, her eyes look like they're kind of bulging out of their sockets, right? If you look at it from the side, you can really see how the eyeballs are kind of bulging out. And the reason this occurs is because in Graves' disease, which you remember is an autoimmune disease, there is a separate autoantibody that attacks the tissues behind the eyeballs. And of course, that attack on the tissues leads to swelling and hypertrophy of that tissue. And as the tissue behind the eyeballs swells, it pushes the eyeballs forward, so they kind of stick out like that. Now, what do you suppose is the problem with having exophthalmos, other than the way it looks? Okay, well, the eyes get dried out easily, right? Because they stick out so much, it's hard to close the eyelids completely, especially at night when people are sleeping. I don't know if you've ever seen somebody who sleeps with their eyes open, but people with exophthalmos have a lot of trouble with that. And sometimes we have to tell them to, get the paper tape, and tape their eyelids shut at night so their eyeballs don't get all dried out. Because the problem is, if their corneas get too dried out, they can start to ulcerate, right, and get infected. If there's a worst case scenario, there might be swelling in that tissues behind the eyeball that puts pressure on the optic nerve, and there may actually be some loss of vision. Now, exophthalmos may or may not be reversible. It kind of depends on how severe it gets. If we catch it early, we correct the hormone balance, then the exophthalmos may reverse. By the time it gets this bad, it may not be totally reversible just by fixing the hormone balance. In these cases, we have a couple of treatment options. We might do a low dose of radiation to try and shrink the swelling in the tissues behind the eyeball, or we might need to do some sort of surgery, either on the eyelids, or maybe some surgery to remove a little bit of the bone or the fat from the eye socket so that it doesn't push the eyeballs forward so much. There would be a little incision made at the inner corners of the eye. I'll let you talk about the ins and outs of all of those kinds of things when you get to adult health too. Now, the other change in physical appearance we said could occur in Graves' disease is a goiter. And a goiter is an enlarged thyroid gland. Now, I have several pictures of goiters to show you because they don't look the same in every patient. Like in this patient, notice the goiter is mostly on one side only. So only one lobe of the thyroid seems to be enlarged in this case. This one is really mostly one-sided as well. And this one is not that obvious, right? If you weren't looking for it, you might not notice it. And this one, I probably wouldn't notice this one either, especially if she was wearing something that had a high neck on it. Now, sometimes the goiters are a little bit more noticeable if you look at them from the side, but this one actually just looks like a woman with an Adam's apple like a man, right? So what I'm trying to say is, look around at all the people that you pass and look at their necks, because the more normal that you look at, the easier it'll be to identify abnormal when you see it. As for interventions for hyperthyroidism, we do have a few options. Our treatment of choice is usually going to be radioactive iodine therapy. What we do in radioactive iodine therapy is we give the patient radioactive iodine, which is iodine 131. And the thyroid picks up iodine and concentrates it, getting ready to make it into hormone, right? So when the thyroid picks up the radioactive iodine and concentrates it in the thyroid, the radioactivity in the area is going to destroy part of the thyroid gland and thus lower the amount of hormone that the thyroid makes. Now, what they have to do is they have to kind of estimate the weight of the thyroid and calculate out a dose of radioactive iodine that will destroy enough of the thyroid to bring the hormone levels to normal limits, but not so much that it's going to make the person hypothyroid. Now, of course, if they do give a little too much and the patient does become hypothyroid, it's not the end of the world, right? We can just give them thyroid hormone replacement. But the thing is, even when we do it correctly and we normalize out their thyroid hormone levels, remember, as people get older, everything in their body gets less efficient, including the thyroid. So we might normalize somebody's hormone levels right at the current time, but as that patient ages, they may eventually become hypothyroid. So we will have to continue to monitor that patient. Now, if the hyperthyroidism is related to a cancer, we would probably have to surgically remove the thyroid. Okay, so we would do what we call a total thyroidectomy. If the patient didn't have cancer, but they had a big, huge goiter, we might do what we call a subtotal thyroidectomy, meaning we remove part of the thyroid so that the goiter is not so noticeable, but we're leaving enough of the thyroid in there that hopefully the patient wouldn't need thyroid hormone replacement. And then our third option would be antithyroid medication. There are some medications that will decrease the thyroid's production of hormone, but that's not our treatment of choice, because what we find is, once we regulate somebody on antithyroid medications, if at some later point in time we try and taper them off of the medication, most cases are going to relapse. Okay? Only maybe 20 to 30% of cases will not need antithyroid medication for the rest of their life. And antithyroid medications, like all medications, have side effects. And so that's the reason why antithyroid meds are not our treatment of choice, because most people would have to be on them for the rest of their lives. We would probably choose this option if we had a patient who we didn't think could tolerate the more aggressive therapies like radioactive iodine or surgery. So, for example, if we had a young child or we had a pregnant woman, we might choose antithyroid medications. Now, there is a life-threatening or crisis form of hyperthyroidism. We call it thyroid storm or thyroid crisis. It doesn't happen very often. It mostly only happens in people who have been undiagnosed or untreated for a long period of time. But when it occurs, it is considered a medical emergency. So that's why, even though it doesn't happen very often, you still need to learn about it. Okay, so the symptoms of thyroid storm are pretty much the same as hyperthyroidism, only much, much more severe. Okay, so instead of just being heat intolerant, these people are running high fevers. Okay, instead of just being nervous and irritable, they might be agitated or even delirious. And instead of just having tachycardia, their heart rate may be so fast that they're having angina, or they're actually going into heart failure because their ventricles don't have time to fill. Okay, sometimes the thyroid storm occurs in somebody who has undiagnosed hyperthyroidism, hasn't been treated, and then they, experience some severe physical or emotional stress or some big trauma. So oftentimes people have other problems in addition to the thyroid storm, and that can make treating them kind of tricky. So you can understand why these people are critically ill and usually are treated in the ICU. All right, let's talk now about hypothyroidism, lower than normal levels of thyroid hormone, and we'll compare it to what we just said about hyperthyroidism. So there are also several forms of hypothyroidism, and the most common would be autoimmune as well. Only in the case of hypothyroidism, it's the kind of autoimmune disease that you would normally think of, where the immune system is attacking the thyroid and kind of damaging it so it's unable to produce adequate levels of hormone. The most common type of hypothyroidism is Hashimoto's thyroiditis, and that is a autoimmune disease. So it's kind of interesting because the most common form of hyperthyroidism and the most common form of hypothyroidism are both autoimmune diseases. All right, so lower than normal levels of thyroid hormone is, of course, going to decrease the metabolic rate. And so now we're going to see most body processes sort of slowing down. All right, so if the basal metabolic rate drops, then we don't need as much oxygen. So what do you think is going to happen to respiratory rate? It's going to decrease, right? So people are sort of hypoventilating now. Okay, and since we don't need that much oxygen circulating around to the different body cells, what do you think is going to happen to cardiac output? Cardiac output's going to drop, right? The heart rate's going to slow, the force of contraction is going to decrease, there's not as much circulation, so, the skin and the sebaceous glands in the scalp aren't going to be making as much oils, so now we're going to have hair that's kind of coarse and brittle. We're going to have skin that's kind of rough and dry. And if the cardiac output drops, there's not going to be as much blood flow to the kidney. So what do you suppose is going to happen to urine output? Yeah, it's going to drop, right? And so people are going to sort of be retaining water. And that's going to give them sort of a swollen, puffy look, right? Also, if the cardiac output drops, blood flow to the brain is going to decrease. And so people are going to be a little mentally dull. Okay, they'll be kind of lethargic. Their memory might not be that great. They're going to feel tired and weak. They're going to move slow. They're going to be kind of clumsy because their brain isn't getting as much blood flow. All right. Now, you remember heat is a byproduct of metabolism, right? So what do you think is going to happen to heat production in the hypothyroid patient? Heat production is going to drop. So now we have people with what we call cold intolerance. They're cold all the time. They wear lots of clothes. They have blankets on. Probably the one thing that you don't want to do is put the hyperthyroid and the hypothyroid patient in the same room. Right? Because one's going to be hot, the other one's going to be cold, they're going to be arguing over the thermostat. Of course, if they did have an argument over the thermostat, who do you think would win? Yeah, the hyperthyroid person, right? Because the hypothyroid person would be like, okay, I'm cold, but whatever. I just don't have the energy to argue with you. All right, so what do you think happens to the appetite of the hypothyroid patient? It decreases, right? But what happens to their weight? They're going to gain weight. Why is that? If they're not eating as much because their appetite has dropped, why are they gaining weight? Because their basal metabolic rate has slowed so much, right? So talk about depressed, right? Here are people who aren't eating that much and they're still gaining weight. That's going to just contribute to a poor body image and depression because remember, they're also kind of retaining fluid, right? So there's that puffy look. In the GI tract, what happens to peristalsis? It's going to slow down. So people are going to complain of constipation. Right? And there might be some abdominal distension and flatulence that goes along with that constipation. Now, also in the GI tract, the metabolism of cholesterol is going to slow down as well. So, what do you think happens to blood cholesterol levels? Those are going to go up, right? And people with high cholesterol levels, what are they at risk for? Yeah, atherosclerosis and heart disease and all the things that go along with that. Okay, now, think about all the stuff that we've talked about so far in relation to hypothyroidism. Can you see how it can easily get mistaken for just somebody who's getting old? Right? Because in older people, their metabolic rate slows down, so they start gaining weight. Older people are often cold. They complain of being constipated and they're always worried about whether they had a bowel movement that day or not. Their cholesterol levels go up. Okay, can you see how common it could be for somebody to go to the doctor and complain of these things, and the doctor would be like, well, what do you expect? You're not getting any younger, you know. So we need to be really careful that we don't just, assume that some of these things are due to aging. We need to make sure we're doing a good physical assessment. All right. We kind of already talked about the energy and the activity level. We said that people get very tired, they get lethargic, and as far as changes in their physical appearance, aside from the fluid retention and the weight gain, people with hypothyroidism can develop a goiter, and they can develop a condition called myxedema. Okay, now, myxedema refers to a non-pitting type of edema. Do you know what I mean by non-pitting? Maybe we should start by talking about what pitting edema is first, right? Okay, so pitting edema is what happens when you press your finger on a swollen place in somebody's body and you leave a fingerprint when you lift your finger, right? A non-pitting edema would be when you press your finger into a swollen place in somebody's body and you don't leave a fingerprint when you lift your finger up. Okay, now the reason why you do leave your fingerprint in pitting edema is because if there's a lot of fluid in the interstitial space, that fluid is thin like water, right? So when you press down on it, you're displacing the water from where it's collected in the interstitial space. And when you remove your finger, it takes a while for the fluid to return to where it was. And so, the fingerprint stays there and it just sort of gradually disappears. In myxedema, there is no pitting because what's collecting in the interstitial space is not a thin, watery type of fluid, but it's more of a mucousy or more like a gel consistency of a substance that's in there. So since it's thicker than water, it doesn't displace as easily when you press your finger in it. So you're not going to leave a fingerprint. Okay, so the substance that's collecting in the interstitial spaces in myxedema is what your book calls a mucopolysaccharide substance, which attracts water. Okay, so we've got this mucousy gel type substance that's attracting water, and that's what's causing the swelling. We don't actually know why that happens, but we do know that when it collects there, because it doesn't displace so easily, you see the swelling, but it doesn't pit. Okay, now this myxedema is most obvious in the face, usually around the eyes. So a lot of times in hypothyroid patients, you see these big bags under their eyes. So here's another picture of someone with the really big swollen bags under their eyes. And sometimes it can affect the tongue. So the tongue gets a little enlarged and maybe their speech becomes a little slurred. Their voice might become a little hoarse or a little husky sounding. You can see in this patient the tongue is a little bit enlarged, so it's kind of sticking out a little. But actually, myxedema can affect other body parts as well. Here you see it in someone's feet. But it can also affect internal organs, like your heart. If it does affect internal organs, then we might expect to see some changes in the function of those organs. And again, remember that goiter may or may not be present in hypothyroidism. Now, the logical intervention for somebody with hypothyroidism would be, let's give them some hormone replacement, right? And here you can see a before and after picture. Before we started the patient on hormone replacement and after. And you can see, of course, she's lost some weight, but you can just see how much more alert she looks, right? Look at her eyes. And the same thing with this gentleman. Although, I have to say, if I didn't see the before picture, he doesn't look all that peppy in the after picture either, but he does look a lot more alert. if you know what he looked like before he was treated, right? And here's one other picture, and I'll let you talk all about the ins and outs of replacing the thyroid hormone when you get to adult health too. All right. Now, just like with hyperthyroidism, there is also a life-threatening or end-stage form of hypothyroidism. We call it myxedema coma or myxedematous coma. And again, it doesn't happen very often. It usually only happens in people who have been untreated and undiagnosed for a long period of time. But when it does happen, it is considered a medical emergency. And so again, even though it doesn't happen very often, you still need to learn about it. Okay, so the symptoms of myxedema coma are just like the symptoms of hypothyroidism, only much, much more severe. Okay, so instead of people just being cold all the time, they're actually hypothermic. Their body temperature is way below normal. Instead of just having a slow respiratory rate, they'll really be hypoventilating. Instead of just being lethargic, they might be in a coma. And instead of, just having a slow heart rate, they might actually be, going into shock because their cardiac output is so slow or so low. Okay, so can you understand why this is a life-threatening kind of situation and why these people are usually treated in the ICU? Now, before we leave the topic of the thyroid, I do want to say a few more words about goiters. Okay, we said goiters were enlarged thyroid glands that you can see as a big bulge on the neck. And you've probably already noticed that we said goiters can occur in hyperthyroid patients and hypothyroid patients. Interestingly enough, they can also occur in euthyroid patients. Euthyroid meaning people with normal thyroid hormone levels. Okay, so notice that just because you see a patient has a goiter, you still don't really know what's going on with them, right? They could be hyperthyroid, they could be hypothyroid, or they could even have normal levels of thyroid hormones. So seeing the goiter really tells you nothing about their hormone status, right? If you see a patient with a goiter who has high thyroid hormone levels, it's usually because they have some kind of growth, a tumor or a nodule on their thyroid that is overproducing thyroid hormone. Or it could be that they have an autoimmune disease where the autoantibodies are overstimulating the thyroid, kind of irritating it so it's swollen and enlarged, but it's also overproducing hormones. So if you see a goiter in a hyperthyroid patient, it's usually due to one of those things. If you see a patient with a goiter whose thyroid hormone levels are low or normal, usually that enlargement of the thyroid is a compensatory response to low thyroid hormone production. Here's how that works. So the patient will start out with low thyroid hormone levels, and the feedback mechanism kicks in and tells the anterior pituitary, wow, I have really low levels of thyroid hormone. Can you make more TSH and tell the thyroid to make more thyroid hormone? So the anterior pituitary will make more TSH. And you remember that TSH not only tells the thyroid to make more hormone, but it also stimulates the thyroid to grow. So if we have a lot of TSH, the thyroid's going to get bigger, and as the thyroid gets bigger, in some cases, that enlargement enables the thyroid to make adequate levels of thyroid hormone. So now you have somebody whose thyroid hormones are normal, but they have this big, huge goiter, right? In other people, it doesn't matter how big the thyroid gets. There's something wrong with that thyroid, and it still can't make enough thyroid hormone. So now you have somebody with a big, huge goiter, and they still have thyroid hormone levels that are too low. So do you see what I mean when I say it's a compensatory response to low hormone levels, right? Because the thyroid hormone levels are low, the feedback goes to the anterior pituitary, which makes more TSH. The TSH encourages the thyroid to enlarge, and in some situations that enlargement is enough to bring the hormone levels back to normal limits. So now you have the euthyroid patient who has a goiter. In other patients, no matter how big the thyroid gets, it can't make enough hormone, so now you have a hypothyroid patient who has a goiter. Does that make sense? Okay, so when you see a patient has a goiter, again, remember, you still really don't know what's going on with them. You don't even have a clue as to what their hormone levels are like. So we're going to have to go in and measure that and figure out which one of these problems the patient has before we can appropriately treat them. Now, it is possible for a goiter to get so big that it can start to compress the esophagus or the trachea, in which case the patient might start to have trouble swallowing and breathing. And I'm showing you this picture so that you can see that, yeah, it is possible for a goiter to get big enough to interfere with swallowing and breathing. Of course, this situation is pretty rare. This photo was given to me by a colleague whose father was a physician in the mission field, and he took this picture of one of his patients. Obviously, this gentleman came from a part of the country where he didn't have access to medical care. You wouldn't probably see someone with a big, huge goiter like this in our country, because way before it got that big, somebody would be like, whoa, I think you ought to get that checked, But there have been stories of people who are like reporters or weather people on the news who somebody calls in and says, wow, I see something on your neck, you better go get that checked. And they actually found they had thyroid cancer or something like that. So anyway, again, get used to looking at people's necks, all right? All right, now we're going to look at some diseases of the adrenal gland. And the adrenal gland's a little bit more complicated than the thyroid because it makes more different hormones. So that means it's more important than ever that you don't just memorize symptoms of diseases, but that you try and understand the concepts that are involved. Now, I'm not saying that there's nothing that you will have to memorize. There are some things that you are going to have to memorize, like, if you have a disease that's named after someone, that really gives you no clue as to which hormone's involved and whether it's a hyper or a hypofunction disorder. So there are a few things that you will have to memorize, but I tried to summarize everything that you would just have to memorize in this little chart here. And so what we're going to do is we're going to walk through this chart today. If you memorize the stuff on this chart, everything else you should be able to figure out just by using logic. Okay, so you will probably have to memorize. See, we have a lot of diseases that are named after people here. So what hormones involved? Is it a problem with too much or not enough hormone? And of course, if you don't already know what these hormones do, you will probably have to memorize that as well. But once you've got that down, everything else you should be able to answer by logic. All right, so you remember that the adrenal gland has two parts, right? There's an outer cortex and an inner medulla. Okay, we're going to start by looking at the cortex. So the adrenal cortex makes three different kinds of hormones. It makes mineralocorticoids, glucocorticoids, and sex hormones. Now these hormones are called corticosteroids because they come from the cortex and they all have that steroid chemical structure. So they are corticosteroids. Okay, now these steroids are considered, quote, essential for life. Meaning that if for some reason your cortex decided to stop making these, probably you would die within the space of a few days to a couple of weeks. Let's talk about the mineralocorticoids first. The primary mineralocorticoid that your cortex makes is aldosterone. And you remember the main job of aldosterone is to make you save sodium and lose potassium. Now, of course, if you save sodium, what else do you save? You save water, right? But remember, the primary effect of aldosterone is on sodium and potassium, and the water is a secondary effect. All right. And of course, you remember the thing that determines how much aldosterone you're going to produce is the renin-angiotensin-aldosterone system. So aldosterone production is regulated by the kidneys. The primary glucocorticoid that your cortex makes is cortisol. And cortisol functions as part of your stress response. It's sort of considered a stress hormone, and as such, it has several effects. First of all, it raises your blood glucose levels because, if you're in a crisis, you might need glucose for energy to respond to that crisis. So cortisol raises your blood glucose levels, and it does that by breaking down fats and proteins and converting them to glucose. Another thing that cortisol does is it decreases the inflammatory response. Okay, when you first think about that, you might wonder, why would we want to do that? Okay, what would be the purpose of decreasing the inflammatory response during a crisis? Well, let's think about that. Do you remember what the symptoms of inflammation are? Redness, heat, pain, swelling, loss of function, right? So how well do you think you'd be able to respond to stress if you have a lot of redness, heat, pain, swelling, and loss of function? Probably not that well, right? Not to mention that it takes energy to generate inflammation, energy that we'd probably rather save to deal with the stress. Okay, so there is a useful purpose for decreasing the inflammatory response. And, just as an aside, because we know cortisol decreases inflammation, we sometimes give people synthetic cortisol to treat chronic inflammatory diseases because it decreases inflammation. Okay, we'll talk more about that later. Okay, unfortunately, cortisol doesn't just decrease the inflammatory response, it will also decrease the immune response. Okay, so if you have too much cortisol, that can increase your risk for infection. But fortunately, in the amounts that your body normally produces, what we call physiologic amounts of cortisol, that's usually not enough to seriously impair somebody's immunity. But, if the patient is under stress, cortisol gets released as part of the stress response. If the cortisol levels stay high for long enough, it will decrease immunity and people are more at risk for infection. I remember when I was a nursing student, I would always get really stressed during test week. And so I imagined that my cortisol levels were high during test week and my immunity dropped. And I would always get some kind of cold and I would always be sick during vacation, right? They've actually done studies on people who run marathons. And I would say running 26.2 miles is kind of stressful, right? But what they did in this study is they took these people who had run a marathon and measured their cortisol levels after the race, and then they followed them for a couple of weeks to see who got a cold or who developed some sort of infection after the marathon. And they did find a correlation between the higher the cortisol levels went up, the higher the likelihood that the patient would get an infection afterwards. So, if you have large amounts of cortisol, then it will impair your immunity and you will see people at higher risk for infections. Now, I did just say that we sometimes give people synthetic cortisol to decrease inflammation if they have an inflammatory disease like asthma or rheumatoid arthritis. And at the levels that we give when we're treating somebody with synthetic cortisol, what we call pharmacologic levels, that is enough to impair somebody's immunity. So we don't just put people on synthetic cortisol for fun, right? Because it is going to impair their immunity, and so we are taking a risk. And we have to make sure that the benefit is going to outweigh the risk. By the way, in case you're wondering, if you want to know some examples of a synthetic cortisol type drug, that would be something like prednisone or hydrocortisone, dexamethasone, some kind of synthetic glucocorticoid. All right. Now, the last thing I want to say about cortisol is glucocorticoids do have some mineralocorticoid properties. Okay, so glucocorticoids will make you retain sodium and lose potassium. And the logic behind that is it seems like whenever people are under stress, the body's always afraid that this person's blood pressure is going to bottom out and they're going to go into shock and they're going to die, right? So this stress hormone cortisol is going to put into motion something to prevent that from happening. So cortisol will make you retain sodium, which makes you retain water, so that you maintain your blood volume, and therefore your blood pressure will not bottom out, you will not go into shock and die. Okay, so there is a logical reason for all the actions of cortisol. All right, what about the sex hormones? The adrenal cortex actually doesn't make very much sex hormones. It primarily makes androgens. And it doesn't really even make that much androgen either. It's only a very small amount compared to how much your reproductive organs produce. Right? So it's not really enough to affect anyone's sexual function or whether or not they can have children, but it could be enough to affect secondary sex characteristics. So like how much body hair a person has, what their body build is like, how high or low their voice is, that kind of thing. Okay, but again, not nearly as much androgen being produced as your reproductive organs. And of course, you remember that while aldosterone is regulated by the kidneys, cortisol and the androgen production, those are regulated by the anterior pituitary through the production of ACTH, right? And there you have the 3 hormones that your adrenal cortex makes. Some people remember them by thinking about the 3 S's: sugar, salt, and sex. All right. Now, before we move on, there are a couple of things that I want to say, and that is, remember we said that these hormones that the adrenal cortex makes are corticosteroids, right? Because they have that steroid chemical structure. But remember that not all hormones have that steroid chemical structure. Like thyroid hormone does not have the steroid chemical structure. So steroid and hormone are not the same thing, okay? The other thing that I want to say is that in the hospital, when we talk about putting someone on steroids, we are usually talking about putting them on synthetic glucocorticoids or synthetic cortisol, okay? Now, all 3 of those hormones from the cortex are steroids, but when we say in the hospital we're going to put somebody on steroids, we are referring to the synthetic glucocorticoids. Okay, of course, I guess it depends on who you hang out with, right? Because if you hang out with a bunch of bodybuilders and they talk about somebody who's on steroids, are they talking about somebody who's taking synthetic glucocorticoids? No, they're talking about somebody who's taking androgens, right? But in the hospital, when we say we're putting somebody on steroids, we are talking about the synthetic glucocorticoids. All right, so if you're looking at this chart, we're talking about the cortex, okay, and we're going to now talk about some hypofunction disorders of the adrenal cortex. Now, when there's a hypofunction of the cortex, usually there's a deficiency of all 3 of those hormones that we just talked about. So there really is only one hypofunction disease that we have to learn, but there is, however, both a chronic and an acute form of that disorder. Let's talk about the chronic form of the disease first. It's called Addison's disease. Just in case you were wondering, there is a Dr. Addison that this disease was named after. There's his picture. And Addison's disease is usually an autoimmune disorder. And it's usually one of those chronic diseases that occurs in cycles of remissions and exacerbations. All right, let's remind ourselves what the cortex hormones do, and then we'll see if we can figure out what symptoms people with Addison's disease will have. Okay, let's look at aldosterone first. aldosterone raises sodium levels, right? So if you don't have aldosterone, what's going to happen to sodium levels? They're going to drop, right? And if sodium levels drop, what happens to water? We lose water too. And if we lose water, we become dehydrated. And if you're dehydrated, what happens to your blood pressure? That's going to drop too. So we're going to see people with either orthostatic hypotension or, hypotension all the time, depending on how volume depleted they are. Now, aldosterone lowers your potassium. So if you don't have aldosterone, what happens to your potassium levels? They're going to go up, right? And what are we most worried about with potassium imbalances? Okay, well, remember, we need potassium for muscle function, and if our muscles aren't functioning, we're going to have muscle weakness. But what is the most important muscle in your body? Your heart, right? So we're most worried about monitoring for cardiac dysrhythmias. All right, people with Addison's disease also have low levels of cortisol. And you remember that cortisol raises your blood glucose level, right? So if you don't have cortisol, what do you think is going to happen to your blood glucose levels? It's going to drop, right? So we're going to have people with hypoglycemia. Now, what do people with hypoglycemia usually feel like? Tired, weak, lethargic. They might lose weight. They might not have much of an appetite. They might have nausea. Okay, and you also remember that cortisol is part of your stress response, right? So if people don't have very much cortisol, they're going to have poor tolerance to stress. Okay, so in other words, when they get into situations where there's severe physical stress, they might more easily go into shock than somebody who doesn't have Addison's disease. All right, so people with Addison's disease will also have low levels of androgen, but, we did say that the cortex really doesn't make all that much androgen anyway, and, you're not really even going to notice that loss of androgen in men, right, because they have so much androgen from their reproductive organs. Even in women, probably the only thing you're really going to notice from the lesser amount of androgen is maybe a little less body hair, and really, who cares, right? That's not something that we're really going to be worried about in the clinical setting. Now, one interesting symptom that goes along with Addison's disease is what we call hyperpigmentation. Now, what do you suppose hyperpigmentation means? Well, hyper means too much, right? So we have a lot of pigment. People with Addison's disease usually have very tanned or bronze skin. Sometimes people refer to it as a eternal tan, okay? And the reason why they have this hyperpigmentation has to do with the feedback mechanism. Okay, so you remember that in Addison's disease, we're not making enough aldosterone, cortisol, and androgen, right? So the feedback's going to go to the anterior pituitary and say, I don't have enough cortisol. You should make more ACTH. Okay, so the anterior pituitary responds not just by making more ACTH, but also by making more of another hormone that it produces called MSH. Now, MSH stands for melanocyte stimulating hormone. And do you remember what a melanocyte is? Yeah, melanocyte is a cell that produces melanin, which is the pigment that gives your skin its color. Okay, and I think the reason why the anterior pituitary makes more MSH as well as ACTH is because, as you can see from this little chart, ACTH and MSH actually share the same chemical precursors, and they actually have a fairly similar chemical structure. So bottom line is, when the feedback mechanism kicks in and the anterior pituitary makes more ACTH, it also makes more MSH. And so people get tanned skin. So this patient actually reminds me of the first patient I ever worked with who had Addison's disease. She was about this age, and she had blonde hair and blue eyes and a really great tan, right? So I walk into the room to introduce myself, and I'm like, wow, have you been to the beach? Because you have such a nice tan. And she was like, well, I haven't actually been outside much, but my doctor says that's part of my disease. And I was like, ugh, I knew that. I mean, that's a great example of what happens when you walk into your room to talk to your patient and you haven't engaged your brain, right? But anyway, a lot of times if you don't, know that this person has Addison's disease, you will just think this is a person with a really great tan. So while on paper it looks obvious, oh, hyperpigmentation, I know what that is. In real life, it can sometimes be hard to tell the difference between somebody with hyperpigmentation and somebody who's just been out in the sun. And I just threw this picture in because have you ever noticed that every picture that you see of John F. Kennedy, he looks like he has a really great tan, like he just came back from vacation? Okay, it's because he had Addison's disease, so he had that hyperpigmentation. But, his disease was being treated, so, you can lead a perfectly normal life if your disease is well controlled. He only died because somebody shot him, right? Now, I did actually read an article where somebody hypothesized that maybe he wouldn't have died if he didn't have Addison's disease, because you remember we said that Addison's disease, when you're missing cortisol, you might have a poor tolerance to stress. And so their hypothesis was, if he didn't have that poor tolerance to stress, he might have been able to pull through. We don't know that for sure, but it's interesting to think about, right? Now, just in case you're thinking, ooh, I would like to have Addison's disease because then I could have a nice tan without having to, spend time in the sun and risk getting skin cancer. Well, this is not the way you want to get your tan, because a tan is not always a nice, even tan. Sometimes people with Addison's disease have another autoimmune disease that goes along with it that's called vitiligo. And in vitiligo, there is a problem with the, the cells that produce melanin, and so you might see some little patchy areas of much lighter skin. So a lot of times people with Addison's disease have a tan, but it might have blotchy areas, and it's not always a nice tan. Now, the logical intervention for somebody with Addison's disease would be to replace the hormones, right? We might try and get away with just replacing the glucocorticoid, because remember we said that glucocorticoids do have some mineralocorticoid properties. And if we can get away with just replacing one medication instead of two, that's usually easier on the patient. But if we do replace just the cortisol and the patient still has some fluid and electrolyte problems, we will go ahead and add a mineralocorticoid replacement as well. Okay, so that was the chronic form of hypofunction of the cortex. That was Addison's disease. But remember, there is an acute form of it as well that we call Addisonian crisis. Addisonian crisis is sometimes called acute adrenal crisis because it can be life-threatening. Okay, now remember we said that these corticosteroids were, quote, essential for life, right? And that if for some reason your cortex stopped making these hormones, you might die in the space of a few days to a couple of weeks. Now there are two groups of people who are at risk for Addisonian crisis. The first group are people who actually have Addison's disease, because you remember that people with Addison's disease are deficient in those corticosteroids, but they do okay if we give them hormone replacement. But the thing with the hormone replacement is the dose of that is the same every day, right? Now, in people who don't have Addison's disease, The amount of cortisol that is produced will differ depending on the patient's circumstances. And if the patient runs into kind of a crisis, they get a bad infection or they get into a car accident, their adrenal cortex can temporarily increase the amount of cortisol that's produced to get us through the crisis so we don't go into shock and die, right? But people with Addison's disease, we're treating them with a specific dose of cortisol, and that dose does not necessarily automatically increase when that patient gets under stress. And so if a patient with Addison's disease should encounter some severe stress, they might go into Addisonian crisis because they aren't getting the increase in the amount of synthetic cortisol that they would need to keep them out of crisis. So we need to teach people with Addison's disease that should they encounter some fairly severe stress, like they're going to have surgery or they're going to have a root canal or they get an infection or something like that, they should go to their doctor who can temporarily increase their dose of synthetic cortisol to keep them out of Addisonian crisis until the crisis is over. They should also probably be wearing a medic alert bracelet so that, if they do go into Addisonian crisis, if the paramedics come and find them passed out on the sidewalk, they'll actually know what the problem is and can give them cortisol right away without having to wonder, did this person overdose on drugs? Did this person have a heart attack? Did this person have an anaphylactic reaction? They'll know right away how to treat the patient. The second group of people who are at risk for Addisonian crisis are people who do not have Addison's disease, but who are what we call, quote, steroid dependent. Okay, so you remember that we said that we sometimes put people on synthetic cortisol because it does have anti-inflammatory properties, right? So people with chronic inflammatory disorders like rheumatoid arthritis might be on some fairly high doses of synthetic cortisol. But when we put people on high doses of synthetic cortisol like that, it can throw the feedback mechanism out of whack. Because what happens is, when we give people high doses of synthetic cortisol, the feedback goes to the anterior pituitary saying, wow, I have a ton of cortisol. You don't need to make any more ACTH. Right? So the anterior pituitary doesn't make ACTH. The cortex doesn't get the message to make any cortisol. It really has nothing to do, right? So the cortex is just going to sort of kick back and atrophy. And once the cortex is atrophied, if for some reason we were to stop giving synthetic cortisol to this patient, their cortex would not be able to make enough cortisol to keep this patient out of Addisonian crisis because the cortex is all atrophied, right? The higher the dose and the longer the patient is on that synthetic cortisol, the more likely they are to become steroid dependent. And, if a patient does become steroid dependent, that doesn't necessarily mean that they have to take steroids for the rest of their life. It just means that we can't stop it all of a sudden. We can taper the person off gradually, and that will give the cortex time to gear back up until it can produce enough cortisol again to keep this person out of Addisonian crisis. But we do have to teach people who are steroid dependent that they cannot just stop taking their steroid all of a sudden. If they get the flu and they can't keep their pills down anymore, they need to go to the doctor and maybe get their synthetic cortisol by injection. Otherwise, they're going to go into Addisonian crisis. Does that make sense? Oh, and the other thing I want to say is the longer the person was on the steroid, the longer it's going to take us to taper them off. So, if somebody has been on fairly high doses for a long period of time, what we would have to do is put them on what we call a decreasing schedule. Maybe we'll start by lowering the daily dose, and when it gets fairly low, we're going to start giving it every other day, and then we'll move to giving it every third day. And, depending on how long they've been on it, it could take us up to a year, maybe, to totally get them off of it. So, these patients also need patient education and also might need to wear a medic alert bracelet just in case. As far as symptoms of Addisonian crisis, it'll be pretty much the same as the symptoms of Addison's disease, only way, way more severe. Okay, so they'll be very hypoglycemic. They will have low sodium and high potassium levels, probably to the point where they might be having cardiac dysrhythmias. They will be so dehydrated that they'll be hypotensive. And, this is the reason why they might go into shock, right? Very weak, again, critically ill. So patients in Addisonian crisis are going to be treated in the ICU. All right, we're still talking about the cortex, but let's talk now about hyperfunction diseases. As far as hyperfunction of the cortex goes, unfortunately, there is a different disease for each of the 3 hormones. Of course, it is possible to have more than one of those diseases at a time, but we're going to talk about them separately so we don't get ourselves all mixed up. All right, let's talk first about hyperaldosteronism, where we have too much aldosterone, otherwise known as Conn syndrome or Conn disease. And there's Dr. Conn. So hyperaldosteronism means there's too much aldosterone. So what do you think is going to happen to sodium levels? Well, aldosterone makes you retain sodium, so your sodium levels are going to go up, right? And if your sodium levels go up, what happens to water retention? That goes up too, right? And if you're retaining water, what's going to happen to your blood pressure? It's going to go up, right? So hyperaldosteronism is actually a good example of something that can cause secondary hypertension. Remember, we said secondary hypertension is when there's a disease process that's causing your blood pressure to go up. And if you can fix that disease process, the hypertension should go away. Okay, so in the case of hyperaldosteronism, it's the high levels of aldosterone that are making the blood pressure go up. If we can fix that, the hypertension should go away. So here in this diagram, you can kind of follow it along. The high aldosterone makes you retain sodium, which makes your blood pressure go up. But when you have high sodium levels, that also makes you kind of thirsty, right? If you're hypernatremic, you get thirsty, you drink a lot. We call that polydipsia. Now, aldosterone also makes you lose potassium. So if you have hyperaldosteronism, what's going to happen to potassium levels? They're going to drop, right? And what do we worry about when people have low potassium levels? We worry, again, about muscle function, right? And the most important muscle in your body is your heart. So again, we're worried about cardiac dysrhythmias. So I've kind of added that into this little diagram, the low potassium, the cardiac dysrhythmias. But remember, when we talked about fluid, electrolyte, and acid-base balance, we also said that when people are hypokalemic, they tend to go into alkalosis, right? Remember what happens? They are hypokalemic, so we're going to shift potassium out of the cell to bring the potassium levels in the blood back more towards normal. But if the potassium shifts out of the cell, something else that's positively charged has to shift in. What goes in is hydrogen ions, and since hydrogen represents acid, and you have acid leaving the blood going into the cells, then the blood becomes more alkalotic, right? So we expect people with hyperaldosteronism to have some degree of alkalosis. All right, so we know in hyperaldosteronism that the potassium levels drop, right? And the body knows that potassium is very important. So the kidneys are going to kick in and try and save potassium so that it doesn't get too low, right? So as a compensatory mechanism, the kidney's going to start saving potassium. And if the kidneys save potassium, it's going to have to dump sodium. And when the kidneys dump sodium, water's going to follow. And so the patients usually have polyuria. Now, maybe you're thinking this is kind of contradictory, right? Because how can you have polyuria and still be retaining water? Well, the answer to that is because remember you also have polydipsia, right? So you might be peeing a lot, but you're also drinking a lot. And that kind of cancels each other out, and so you could still end up with water retention and high blood pressure even though you have polyuria because you're drinking a lot and you're replacing all the water that you're losing. Does that make sense? Okay, now some of you may still think this is weird because it's like, how is it that the aldosterone makes you lose potassium, but the kidneys are trying to save potassium? That doesn't seem like two opposite things can go on in the body at the same time. Okay, well, this is how you need to look at it. Remember that the high aldosterone is making you lose potassium, and that's part of the disease process. Okay, the kidneys trying to save potassium, that's a compensatory mechanism. That's the body's reaction to the disease process. And that does happen a lot. Remember we said the body always tries to institute checks and balances to make sure nothing gets out of control. So if you have hyperaldosteronism and you're losing potassium, the body's going to try and reverse that. They're going to try and compensate for that by saving. So it's totally logical that you can have two competing processes going on in the body at the same time, because remember, the losing potassium part is part of the disease. The saving potassium part is the body's response to the disease. That's the compensatory mechanism to try and prevent things from getting really bad really fast. Does that make sense now? As far as intervention for hyperaldosteronism, it makes sense to give a diuretic, right? Because we're retaining water and our blood pressure is high. If we give a diuretic, we can kind of counteract that. But we don't just give any old diuretic, because most diuretics don't only make you lose sodium and water, but they also make you lose potassium. And we can't afford to lose any more potassium because we already have hypokalemia, right? So we're going to put people on potassium-sparing diuretics, ones that really only make you lose sodium and water and not also lose potassium, okay? So we're going to put people on potassium-sparing diuretics, okay? Now, sometimes hyperaldosteronism is caused by a little tumor on the adrenal cortex, so we might want to go in and surgically remove that tumor. Or sometimes it's really hard because the tumors are small and the adrenal cortex is a small body part. So sometimes we might go in and just remove the whole adrenal gland, okay? And we can do that because you know you have two adrenal glands, right? So if you remove one, you still have one to hopefully prevent you from having a lot of hormone problems. So those are our options. If we can find the tumor, we'll probably go the adrenalectomy route. Otherwise, we'll put people on potassium-sparing diuretics. All right, we're still on hyperfunction of the cortex. Let's talk about Cushing's syndrome, where we have too much cortisol. And there's Dr. Cushing. Now, there's a bunch of reasons why somebody might have too much cortisol. Maybe they have a tumor on their adrenal cortex that's overproducing cortisol. Or maybe they have a tumor on their anterior pituitary that's making too much ACTH. And the only reason that the cortex is making too much cortisol is because the tumor on the anterior pituitary is making so much ACTH. Maybe they have ectopic Cushing syndrome, where the patient has a cancer or a tumor that's producing ectopic hormone. Maybe the cancer is producing a hormone that's just like ACTH. And so, because you have a lot of ACTH, again, the cortex is making too much hormone. Sometimes people get Cushing-like symptoms because we're giving them high doses of synthetic cortisol. Remember we said we sometimes give people synthetic cortisol to treat inflammatory disorders because cortisol has anti-inflammatory effects. If we give people high doses of synthetic cortisol, they will look like they have Cushing's. Okay, so there are a lot of reasons why somebody might have too much cortisol, but the bottom line in Cushing's disease is there's just too much cortisol. All right, let's remind ourselves what cortisol does and see if we can figure out what happens if you have too much of it. Okay, so cortisol makes your blood glucose go up. So we expect people with Cushing's to have hyperglycemia, right? And we said that cortisol raises blood glucose by breaking down fats and proteins and converting it into glucose. Okay, so we expect to see some problems associated with protein breakdown, right? So we're going to see people breaking down protein in their muscles, right? So they're going to have some muscle wasting. They're going to get very skinny arms and legs because they're breaking down their muscles. And here you can see somebody with the skinny arms and legs because they're breaking down their muscle protein. Also, because they're breaking down protein, we're going to see people with thin skin and poor wound healing. You know, they're breaking down protein, so they're not going to be healing tissue. They're going to be breaking down tissue. We might see people who are more prone to GI ulcers because they might be breaking down protein in their GI wall. We'll see people who bruise easily because they're breaking down protein in their capillary walls. So their capillaries become very fragile and more susceptible to rupture. We also see people with osteoporosis, weak bones. You know, that seems weird at first because when most people think of bones, they think of minerals and stuff. But, you know, there's actually a lot of protein in your bones too. There's collagen and stuff like that, which provides the framework for your bones. And if we're breaking down the collagen in your bones, then we're going to have osteoporosis, and people are going to have pathological fractures because of those weak bones. A frequent place where we see fractures is in the vertebrae. They get compression fractures in those vertebrae, and so they might end up with pinched nerves and back pain. Now, we also said that cortisol breaks down fats as well and converts that to glucose in order to bring the blood glucose levels up. So in our Cushing's patients, we expect to see some abnormal fat metabolism and fat distribution as well. Usually they get what we call truncal obesity, where they are breaking down fat peripherally in their arms and legs, but they're adding fat in the trunk area. So you see this patient with the really skinny arms and legs, but the increased fat deposits in the central area or the trunk area. Now, we think this happens because you remember we said that the peripherally located fat and the centrally located fat are metabolically different, right? The centrally located fat, or the belly fat, is actually an endocrine organ, and it produces a lot of hormones that affect, you know, your glucose metabolism, the blood lipid levels, and, you know, all of those kinds of things. And so we think that the centrally located fat and the peripherally located fat respond differently to the high blood glucose levels that occur in Cushing's. And that's why we break down the peripheral fat and get the skinny in arms and legs, but we're adding fat in the trunk area, the centrally located fat. So people end up with a pot belly, and they might get a cervical fat pad, you know, a fat deposit in the cervical neck region that sometimes people refer to as a buffalo hump. This is what it might look like in real life. Maybe easier to see if you view the patient from the side. This is a huge one, and I'm showing it to you so you can get the idea of what it is, and so you might be more easily able to identify it if it's not so pronounced, as in this picture on the right. Also part of the truncal obesity is what we call moon face, where they have a fat deposit around the neck area because that's still central, right? And because the fat deposits tend to come on fairly quickly when the levels of cortisol go way up, And because the skin is already kind of weak because we're breaking down protein in the skin, very frequently they get a lot of stretch marks in those areas of the fat where the fat has deposited. So the stretch marks might actually be a good indication that maybe there's some Cushing's going on here instead of somebody just gaining weight, right? Because the stretch marks do indicate that the fat deposit happened fairly quickly and that the skin was already weak. And as you might imagine, there are some body image issues that go along with this because sometimes the changes are fairly rapid. And, the terms that are often used to describe what happens, buffalo hump, moon face, pot belly, those are not necessarily the kinds of terms that you want to use in front of your patient. Some other problems that go along with the high levels of cortisol, there is a decrease in the inflammatory response and the immune response. So people are at higher risk for infection. And it might be harder to detect those infections in early stages because there's not that much inflammation that's generated. We also expect to see an elevated sodium level. And so, if people are retaining sodium, they're going to retain water. And if they retain water, their blood pressure is going to go up. So this is another disease that can be considered a cause of secondary hypertension, right? Also, if we're retaining water, we are going to be gaining even more weight. Since cortisol makes you lose potassium, what do you think is going to happen to potassium levels in Cushing's? Potassium's going to drop even farther, and what are we worried about? Muscle problems, cardiac dysrhythmias, right? Intervention is going to depend on what's causing the high levels of cortisol. If there's a tumor on the adrenal cortex, we might just do an adrenalectomy and surgically remove that particular adrenal gland. If it's a tumor on the anterior pituitary, we might try and surgically remove it, or we might just try and shrink it by doing radiation. If the patient has ectopic hormone production, there's a cancer somewhere else in the body that's producing hormone that's just like ACTH, we might try and surgically remove that cancer or, again, do radiation. If we feel like we can't surgically access a tumor without damaging tissue that's vital, we do have some medications that can block the synthesis of cortisol. But again, all medications have side effects. That would probably not be our treatment of choice. Now, I'm going to show you some before and after pictures of patients who had Cushing's and then were treated. And you can see how, the woman's face is thinner. She doesn't have the moon face. And in this one, you can see before she had Cushing's, while she had Cushing's, and then after treatment. And of course, her age is different, but she does look a lot more like her before Cushing's pictures than she looks like her during Cushing's pictures once we've treated her, right? And here's another before, during, and after picture. But again, I want to point out how when you see things like moon face, pot belly, buffalo hump, on paper, it sounds so obvious, but it's not quite so easy to notice in real life, especially if you don't know what this person used to look like, right? Because if you look at that during picture, there are a lot of people who look like that and they don't have Cushing's. So, you really kind of have to know what they used to look like and what the timeline was like and that kind of thing. All right, we have one last hyperfunction disorder of the cortex to cover, and that is too much androgen. Okay, now it doesn't happen very often, but let's just briefly talk about it to round out our picture of the hyperfunction disorders. Now, if this condition happens like the patient's born with it, we would call it congenital adrenal hyperplasia. If it occurs after a patient's already an adult, we would call it adrenal genital syndrome. And as you might imagine, if there's too much androgen, the symptoms that you're going to see are going to depend on whether the patient is male or female and on how old they were when they developed it. Now, if this problem happens in an adult female, what you're going to see is a female who has very masculine secondary sex characteristics. They'll probably have a lot of body hair. They're going to have a more masculine body build. They might even have that male pattern baldness thing going on. Okay, but if this happens in a female infant, then what you're going to see is what we call virilization syndrome, meaning, they're going to look a lot more masculine. And part of that virilization includes what we call ambiguous genitalia. Okay, what that means is, usually you look at a baby and you can tell right away whether it's a boy or a girl, right? Ambiguous genitalia means you look at the baby and you're kind of like, is that a boy or a girl? I'm not quite sure. Okay, so you can see this is actually a girl, but you kind of have to look twice, right? Like, wait a minute, kind of thing. Okay, here's one where the ambiguous genitalia is much more ambiguous, right? Now, if the elevated androgen level occurs in an adult male, you probably won't even notice, right? Because men have so much androgen from their reproductive organs anyway, you won't even notice, right? But if it occurs in a male infant or young child, what you're going to see is a child who develops their secondary sex characteristics very early. In other words, it's going to seem like they hit puberty at a very, very young age. In this photo, the boy on the left has congenital adrenal hyperplasia, and he's 6, right? He started growing body hair and having his growth spurt and basically hit puberty when he was 2, okay? And he's 6 now. The boy he's standing next to is his 8-year-old brother, okay, who does not have congenital adrenal hyperplasia. So you see the boy on the left already had his growth spurt and everything. I don't know why they didn't intervene before he got to this point where he already, grew body hair and, hopefully his growth plates in his bones haven't closed already. Otherwise, he looks tall now, but he's going to end up shorter in the long run. Anyway, intervention for this disorder is going to depend on what caused it, whether it's a problem with a tumor, whether it's a problem with the feedback mechanism. Since it doesn't happen very often, I'm not going to go into that. If you're interested in it, there is more information in your textbook. All right, we're done with the cortex now. Let's move on to the medulla. The medulla is considered to be part of your sympathetic nervous system because it produces epinephrine and norepinephrine, and those hormones also serve as neurotransmitters that mediate sympathetic nervous system activity. Now, if you have a hypofunction of the medulla and you are not making much epinephrine and norepinephrine from the medulla, that doesn't really matter. Okay, because remember, your adrenal medulla is only part of your sympathetic nervous system, and you can get a lot of epinephrine and norepinephrine from the other parts of your sympathetic nervous system. So the medulla, unlike the cortex, is not considered essential for life, and there really isn't any physical disorder associated with hypofunction of the medulla. Hyperfunction of the medulla, though, is a different story. If you have too much epinephrine and norepinephrine being produced by your medulla, that is going to look like sympathetic nervous system overactivity, and it can cause some pretty big problems. So the first thing we probably should do is to review what happens when you have sympathetic stimulation. Remember, sympathetic stimulation is your fight or flight response, and so your heart rate's going to go up, your blood pressure's going to go up, your respiratory rate's going to go up, And your blood glucose levels will go up because, if you're going to do the fight or flight thing, you got to have energy to do that, and you're going to need glucose to generate that energy, right? Now, you remember that epinephrine and norepinephrine are referred to as catecholamines, right? Because of their chemical structure, they have a catecholamine structure, okay? But the most common cause of an increase in catecholamine levels is a tumor that we call a pheochromocytoma. Pheochromocytoma is usually a benign tumor of the adrenal medulla. And because it's usually benign, if we can remove it, then we can kind of cure pheochromocytoma, right? But, you can frequently find these little memory tricks on how to remember the symptoms of pheochromocytoma because they are a lot of things that happen when you have that sympathetic fight or flight response. So if you look at this list of things that occur when you have sympathetic stimulation, these are similar to the symptoms of pheochromocytoma. The blood pressure goes up, the heart rate goes up, and people complain of palpitations because, when you have that sympathetic fight or flight, you not only have increase in heart rate, but there's an increase in the force of contraction, right? People feel like their heart is just pounding in their chest, and they'll break out in this cold sweat, and they get really anxious and really nervous. They'll breathe faster. Their blood glucose will go up, although they may not notice that. But you will notice it when you do tests, right? Now, these symptoms usually are not continuous, but they happen in episodes or attacks. And these attacks might be triggered by things like stress, right? Because stress does make your medulla produce more epinephrine and norepinephrine. Okay, it could be triggered by certain foods or medications because there are some foods and medications that actually trigger the release of epinephrine and norepinephrine. Or it could be triggered by a change in body position, especially if that change in position puts pressure on the tumor in the medulla. I remember the first patient I ever worked with who had a pheochromocytoma. Her tumor was located in a place where if she just kind of bent over to pick something off the floor or she bent over to tie her shoe, that would press on the tumor, and it was like delivering a shot of epinephrine right into her bloodstream. So she would bend over, and then she'd break out in the sweat, and her blood pressure would go through the roof, and she'd get a pounding headache because of the pressure that was put on that tumor. So the symptoms of pheochromocytoma often occur in these kinds of attacks. Now, which of these symptoms do you suppose we worry about the most? Okay, usually it's the high blood pressure, because if the blood pressure gets too high, if this patient has any aneurysms in their brain or in their aorta or whatever, those aneurysms can rupture and the patient could get a stroke or they could, have a major bleed. Of course, if their blood pressure and their heart rate go up, that's also not great for the heart, right? So if they have any kinds of heart problems, we might see the heart being overworked and maybe the patient going into heart failure or something like that. All right. The logical intervention for pheochromocytoma, like I said, if we can surgically remove that tumor, we can cure this person because it's usually not a cancerous tumor, it's benign. If the tumor is not in a place where we can remove it, or if we think that the patient is not a good surgical risk, we do have medications we can give that will block the production or block the effects of epinephrine and norepinephrine. But again, all drugs have side effects, and so that would not be our treatment of choice. All right, that's it for today. Send me your questions, and I will see you in class.